Hello everyone, welcome back. It's been a long time since I've posted a video, y'all. So this is going to be in my The Nursing Corner podcast, but of course I had to retake this video because the volume, the audio didn't work the first time around, but the podcast is out. So today's topic is going to be about nursing differences in Canada versus Australia. So I've been here in Australia for 7 months now, I believe. So yes, I've been working as a nurse in the ward, oncology ward, and I'm just going to talk about my experience and what are the differences that I did not even thought about. There's actually great things that I wish I would have known. It's not a deal breaker. You get used to it. You can get used to the processes here. Don't get too crazy about or getting scared about moving here because there's not much. There's a lot of similarities and there may be some differences, but it's not too major. Well, it's major, but you'll get used to it. It's too common difference that you get used to it after a while. So first is in Canada, at least in Ontario, as long as they haven't privatized anything, so it's primarily like public healthcare system, right? Everyone has the same coverage. Everyone has is entitled to like need to basis. Like for example, in the hospital, they go to the hospital where they're looking at emergency if they need to be in emergency, or they can't really pick a hospital. I mean, they can, but referrals wise, usually they get referred to by their GP where close to them, close to their area or part of their region. Similar to here, but here the patients can actually choose public hospitals versus private hospitals if they have private health insurance beyond their Medicare coverage. So here it's like the States where they have public and private, so they have Medicare and private hospitalization, but they have like not-for-profit private hospitals here too. But that's difference. And if I'm going to talk about hospitalization and coverage and what you get in the hospital, at least in the private sector where I work, the rooms are most of them are private rooms. That's what I noticed. I know we do have like double bed wards, but at least in oncology, they prefer to have the private rooms because it's just easier, especially if the patients are neutropenic, especially for our hematology patients, where we typically separate them from the group. And in addition, like in Canada, the food that they serve in the hospitals, they're not always that great, right? Because it's external companies. It's not like here where they actually make the food in their kitchen. Like they have, you get orders. They have complaints too, but I find the food here, what they serve in the hospital is so much better compared to what they serve in Canada. Second difference, aside from the public and private, is when you get your nursing license or registration, in Canada, you have to apply for your license depending on which province you go to or the province you want to work. For example, I don't know the names for the other provinces, but in Ontario, if you want to work as a nurse in Ontario, you will have to apply or get registration or licensing from the College of Nurses of Ontario. So that's our regulating body. But for here in Australia, wherever you may want to work, if you prefer to work in the state of Victoria or in Queensland area or New South Wales area, it doesn't matter. You go to only one place, which is AHPRA, and I believe it's the Australian Health Regulation Agency. Health Regulation Agency. I think that Health Practitioner Regulation Agency is the acronym for it. So you only go to one place, AHPRA. You register, and then to get your licensing, and then you go follow through the steps. And I believe I posted a video about my AHPRA journey, but I'll link it if I do have it. I don't remember. It's been a long time. So yes, so in Australia, one place, and I think it's the same place where other people registered if they're enrolled nurses or LPNs, RPNs, which what we call in Canada or the States. And so, and then, or if you're a midwife or if you're a doctor, it's the same place. So it's not just the College of Nurses of Ontario, for example, in Canada. Like it's just one place for all health practitioners. third difference, this is actually a big one because I did not know that there's a difference with the medical abbreviations, terminologies, even drug. Well, I guess I can say drug names too, but there's a difference in drug names, but that's fine. The big one really that I was really shocked was the medical abbreviations because when I think of medical abbreviations, I thought it's universal globally, but it's not. So let me give you an example. So for the timing of the drug, like dosing. So if, this doctor wanted to order an antibiotic 3 times a day, in Canada, they would say TID, right? For 3 times a day. But here they call it TDS. So you know how the abbreviations is slightly different? And then if it's twice a day, the doctors in Canada would say BID. But here they would say BD for twice a day. And then for nighttime, for example, in Canada, they would say HS or QHS every night. But here in Australia, they would say NOCTE, NOCTE, or night, or nightly or night. For the timing, whereas when say every 4 hours, so give the drug every 4 hours, in Canada, we would say Q4H as an abbreviation. But here, they would say 4-hourly. I got really confused with that the first time. I had to confirm, is this what it means? Is it every 4 hours? Because I didn't expect it to be just a slight difference in the medical abbreviation part. I understand drug names, but medical abbreviations, I was surprised. And they also call noon here midday, and there's an order for midday. So just to let everyone know. Terminologies like I get paid every bi-weekly, which is the Canadian way of saying every 2 weeks, but here they would say fortnightly. I've been saying fortnightly because I thought it was so cool. So that's just the difference in terminologies. Drug names. So in Canada, I'm so used to getting the name, the generic names, maybe because when doctors order it in the computer, it's the generic name and the brand name, or most of the time it's the generic name that shows up. Plus, what is really covered by the Canadian government are biosimilars, at least in Ontario, biosimilars or the generic names as opposed to brand names. So, for example, if the patient, if they go to the hospital and the patient takes pantoprazole, but they will actually prefer the drug, that brand name Tecta, I believe is the common brand name, but the hospital won't have it. So most of the time, the patient will bring their own brand name because that's what they prefer, if that's what they prefer. But here, at least from what I've gathered in public hospitals here in Australia, they go by generic names. But because it's primarily paper charting here in Australia, at least in the state of Victoria or in Melbourne area, where I got my experience. So it's when I see the orders written by the doctors or the registrars, it's sometimes you get the brand name, which the recommendation is generic name, but you do, because it's handwritten by the doctor, sometimes they might go for the brand name instead of the generic name. So for example, or even patients will ask, can I get a Panadol? Which in Canada, I would say, can you get a Tylenol, please? And here they would say, I think I'm just going to get Panadol. And then, or when you get oxycodone, and they would say, can I get just an Endone? There's a difference in names. Or if the doctor ordered an amoxiclav antibiotic, they would call it here, I believe it's Augmentin DF here for the amoxiclav. And then, or if they order Peptazo or Peptazo, or however you pronounce it in Canada, here they call it Tacocin, right? So there's slight differences in the name. Of course, appearance, like the bowel meds, they would say lactulose. Lactulose is the same. Coloxyl is the same. But there's difference when they don't really have, I'm not sure if they have the brand Restoralax, which is one, but they do use a lot here of the Movicol is the name of the powdered drink to help them have a regular, opening their bowels is what they say. Nicer way of saying it instead of, oh, did you, have a bowel movement today? But they would actually say, did you open your bowels today? I think it's a lot nicer to say as opposed to like, oh, did you, have a bowel movement today? So that's actually a big difference that I thought I would have loved to know to get myself used to the lingo here. Aside from the way they say things, some people really are into the Australian slangs. Like you do get patients who uses this Australian slangs, but you still get, because majority of the people I find here, at least nurses here in Australia, they're from around the world. Mostly are from Europe, like they're maybe Irish, Scottish, or British, but you do get some from Canada or from the States, but primarily British or Irish. But you do learn from them too, and they do have slangs that you may not have heard before, but it was just like new to me. So yeah, but you can always clarify, and they're very nice about it. Wherever you go, nursing is nursing, and there's always going to be bad apples, good apples. But one thing I love about here is because everyone is from everywhere, at least the healthcare practitioners, that everyone understand that there's a difference from where you're coming from your previous experience to here. So fourth difference is the use of directives. So I'm not entirely sure if there's medical directives or if it's allowed here in Australia. But at least when I asked about, do you guys have a medical directive to unblock PICC lines, for example? In Canada, if you need to unblock PICC lines, you would get an order for a cat flow or altiplase. You don't need an order. There's usually a medical directive. So a standing order is not really supported by the College of Nurses of Ontario. But the difference between an order and a directive is that the order is specifically for an individual patient, whereas a medical directive is for a group of patients dealing with some type of procedures or group of patients in particular circumstances. So that's a medical directive. It's like your standing order, but it's for a group of patients. And typically here in Australia, they are used as directives for emergency cases, but I don't see a lot of, at least from where I work. I did ask if they do have medical directives. Apparently it's not really allowed. They're trying to change it, but I do like there is a great advantage with the use of medical directives for a group population, especially if other countries have utilized that one to really get the doctors focus on what is important. For example, that PICC lines. There should be a medical directive that nurses can use cat flow if they're sluggish, or if they needed to unblock PICC lines. They shouldn't have to wait for an order from the registrar or the doctor. They can just have a standing order, or I guess a medical directive, if you want to call it that way. That way you don't have to bother the doctors for it, right? And then, so that's the medical directives here. Although there may be some instances, like for emergency purposes, like for concern about sepsis, where especially for our oncology patients, and where we get an order for blood cultures, we still notify the doctors here. But I find there is a sepsis protocol common in North America. They do have it here too, but you still kind of need to. Any abnormality, you really have to contact the physician. Even sometimes if the patient don't want to take the medication, you still have to notify the physician. So there's not a lot of autonomy, I would say. Everything is in your scope of practice. It's you have to notify the physician. So that's it. So don't, using autonomy is not a big deal. You have to it's safer. You have to pass the baton to who's responsible, right? And so next difference, so that's medical directive in Canada. They're so popular. There's medical directive for everything. Whereas in here, they may not have a ton of medical directives, or it may just be for emergency purposes, but they do have nurse-initiated drugs, like for example, Panadol or Tylenol. Like bowel meds for constipation, like lactulose, Galaxol, Senna. You're allowed to give those medications. They're safe medications. They're not narcotics. They're not anything that could pose a danger to patients, or likely more harm. So there's those drugs that are nurse initiated that patients can that nurses can give without a doctor's order. So we still have to write it as a nurse-initiated order, but it's something that we don't need to contact a doctor for. Then we have, so the last I'm only giving 5 differences in this video. If you want more, let me know. And if you want to share some of the nursing differences that you noticed, then you can obviously comment down in the comment section. The last difference is that majority of the way we document things for documentation or charting here in the state of Victoria, I'm not sure if it's all over Australia because I've only been working here in the state of Victoria, primarily in Melbourne, is primarily paper charting. Whereas in Canada, not all hospitals in Canada obviously are online, but for the most part, there's now online charting or documentation. So that's a big difference. Maybe that's why the orders are a bit like I'm not used to like reading doctors' handwriting. I'm sure I can read it, but not all of them. And I'm not spending a lot of time on, comprehending or understanding or knowing the order, because in Canada it's now mostly online. So you get the order online, you can read it well. The progress notes are there online as well, typewritten. But for here, it's primarily paper charting. And in addition, like for the medical administration record, those are only written by the registrar or the doctors. So they're not rewritten by nurses. So if the page is full, you have to ask the doctor or their registrars or, their juniors or the fellow doctors, what we call it in Canada, to rewrite the orders, the medication orders. The nurses can't rewrite it and have a doctor sign it off on it, no. If you want to do that, you'll immediate order, you have to contact and get a telephone order, which is the space for it is not much, and it's only good, the telephone order is only good for 24 hours. So you end up sometimes calling the doctors like every time whenever that slot is full or when it passes 24 hours. So only the doctors can rewrite those MAR or medication administration record. The nurses can't do it. And I don't see nurses, checking it at nighttime when they're comparing the orders from the previous order. It's not pre-printed, the MAR. So they use the same MAR until the space is finished. And then if that space is finished, the nurses have to notify the doctors to rewrite and create a new MAR. So that's one difference. Not a big deal. And I know some people might like, I'm not used to like paper charting. It's been a long time since I've done paper charting. You'll get used to it. I did my first 5 years of nursing career in Ontario that is still from a big hospital that is still doing paper charting. I don't know if they're doing paper charting now. It's been a long time, but it's not that bad. There's challenges, but there's also benefits. I find it more challenging, but because it's been a while. But since I came here and work, it doesn't bother me as much anymore. Like I would prefer to have online charting or documentation, but Australia will have it soon. They're talking about it, and it'll come. It's expensive, right? Expensive to do the change. So that's about it. So those are 5 nursing difference between Canada and nursing in Australia. That's pretty much it. Thanks so much for watching. Bye now.